care in between. Physics, art, and math guide us down this path. Historical tales come alive, where science and stories dive. Blended facts with heart, knowledge from the start. Need bridge blues we sing to the future memory. Health and science in the mix. Maybrick's got the fix. Complex subjects make
right
clear.
now
Every episode
in ways that we actually acquire knowledge
leads the way.
and ways that make me more efficient.
In the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
Thank you so much for joining with me. It is truly an honor and a privilege.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges.
Hey, welcome to the MedBix Webcast. This is Raman Annamalaju. I'm the host. I want to bring back Dr. Goldman back here and let me talk with him. Sorry that we had a little bit of a technical problem. I'm going to solve that a little bit. Let me bring Dr. Goldman. Welcome.
Welcome. Can you hear me now?
I can hear you perfectly well.
Perfect.
You solved all the problems. You have a beautiful picture behind you. You know, it's a Dr. Goldman. You know, let me introduce Dr. Goldman. He is actually. He is a very vivacious man. When I met him, I was so impressed. He was engaging. He was talking. If you are in Silicon Valley, you're in healthcare. If you don't know his name, you are living under the rocks. So Gary Goldman is everywhere. He's a Lord Krishna. He's everywhere, all the places, all the time, same time. So Dr. Goldman, tell me your background a little bit of yourself. You're a doctor, you're an anesthesiologist, and now you're into the different ventures. So give us a little bit background of yours, if you don't mind.
Happy to. It's never a short story, but I've spent 35 years in healthcare. As you can see, I've got a lot of letters after my name, so I spent a lot of money on school. I started out as a dentist back in the early 80s. And previous to that, as an undergrad, I went to SUNY Stony Brook in New York, which had a very big computer sciences department.
Yeah, very big.
And so being there and being pre-dent, pre-med, it was still very hard not to do a lot of take some courses in technology. But again, we're talking about 1974. So, computers then was taking a big box of cards to a 100,000 square foot facility. But it really initiated my interest in technology from that point. And, and fast forward from there, I had the first Commodore and the first Mac. And what do they say? Whoever dies with the most toys wins. I had the first Handspring, the first BlackBerry, all of those devices. So I was always interested. And then all through medical school, dental school, and then my residency, I was always very interested in the evolving technology that was happening. I did my residency in Boston at Brigham and Women's Hospital in anesthesia in my fellowship. And then after I met my wife, who's a perinatologist, we came out to California because she had gone to med school out here at UCSF. And when we got here, I had a lot of ideas, and we got here in '89, and that was right around the time that the bubble was building for the internet, for the web. But back in those days, we were using a 56K modem dial-up, and we were still using a lot of DOS. So it took an effort to really work with the internet, the web. But I had ideas. I started practice. I was practicing as a full-time anesthesiologist. But I was fortunate enough that one of my partners, his cousin, was the president of Maxtor in Silicon Valley, the hard drive maker. And he was a Harvard, MBA. And I sat down with him one night and had dinner, and I started pitching him some of the ideas.
By the way, if you don't mind, when I bought a first hard drive, I celebrated. I gave a big party in New York City. That's how I wanted to mention it.
No, I remember those days, believe me. And So basically I sat down with him and I started pitching him some of my ideas. And, again, at the time I was practicing full time, but I had an idea, and it was originally based like very early on, we'll call it very early on digital medicine. Or digital health, is the idea of continuing medical education. So in those days, if you remember, we used to listen to cassette tapes, or we would read an article, we'd answer some questions, and we would get our continuing medical education. It wasn't that easy to do. It was complex. Sometimes you traveled to courses all over the place. I said, why couldn't we put it all on this internet and have people access it there, and then in real time, just in time, get their credit and get their education? And I pitched this idea to many, many clinicians who all thought it was a great idea. And everyone wanted to get into the web at that time. So that's where my first experience with entrepreneurism started. And this gentleman helped me write a business plan. And I started pitching my idea to all my colleagues, and we raised $3 million from the colleagues to start this company and build one of the first learning management system platforms in education. So we built that, wound up fast forwarding 2.5 years later, sold that to one of the largest continuing medical education offline companies, Challenger in Memphis, and I had my first exit. Fast forward from that, I've had 3 digital healthcare companies. My second company was during the nursing shortage, and we went to all over India, from Delhi down to Cochin and in Shanghai, and we started training nurses to pass the nursing licensing exam in the United States, brought them over on H-1B visas and put them in a registry model, and we moved 163 nurses into the U.S. And then the third evolution in my informaticist career was I worked for Sutter Health, and we have we had 27 hospitals at the time, and they were putting in electronic healthcare record Epic, and they came to me and asked me to participate in that project because of my previous experience. So I joined that. I was still doing it up until recently for about 12 years, but it gave me the opportunity to travel all around this globe behind us as a consultant for EHR. And everywhere I went, when we ran into our colleagues, everyone was disenfranchised. Everyone really didn't like electronic healthcare records, felt it made them much less efficient as opposed to more efficient. And also, a lot of them were saying, look, with this evolving digital health revolution, a lot of the technology that was coming out at the time, again, this is about 10 years ago, didn't represent our workflows, right? As an anesthesiologist, as a cardiologist, as a nurse, what was being developed in a lot of the technology was being developed by technology people who didn't have an understanding of our clinician workflow. So that's when I decided to start Global Health Impact Fund and Global Health Impact Network. That was between Company 2 and Company 3. And we started out, I would say to a lot of the clinicians that I was working with at the elbow, I said, well, you need to get involved. You need to educate yourself about the technology that's coming out. You need to be able to make yourself available in one way, shape, or form as an advisor, as a mentor, as a consultant for the companies that are developing these technologies, so they have a good understanding of the clinical aspect of it. I said, and most importantly, again, being the capitalist that I am, I said, why shouldn't the doctors be benefiting from all these great companies that are going public and getting acquired? So I said, we should be picking the companies that deserve to get the funding because they're developing solutions that make sense for us with respect to improving what we do as providers and what we do for patients. So that's where it all started, and that was about 6.5 years ago. We started with the fund. I was very lucky because that third company that I started wound up exiting around the same time that we started the fund. So and it was all clinician investors. So many of them rolled their distributions into our fund. So from that point on, we invested in 11 companies in our venture fund, which is all clinician investors. But the due diligence that we did was very heavy on the clinical due diligence perspective. So we would look at companies with the idea of how does this improve our ability to deliver care? How does this improve our ability to take care of patients? So we picked 11 companies that we invested in. We've already had one exit. We've got 2 more coming, and it's over all different subverticals within medicine. And in the back end, we started building the network. The network was a place that was a community-based environment, secure. It has the functionality of LinkedIn, Slack, Dropbox, and Zoom. And it allows our members to collaborate, communicate, educate, and participate in the companies that we invest in and the other companies that we don't invest in, but we're quote unquote accelerating or escalating those companies. So fast forward now, we've got 400 communities. We've got several thousand clinicians in our network. Our network is doing a global expansion, and it's now going into Africa, all over India, Europe, and the Middle East, including North America. And we started a second fund, a much larger fund that's also now investing in new digital health technology. One thing I will say is I've become very convinced that the future of healthcare is going to be based on data, how we collect the data, what we do with the data, how we manage the data, both on the phenotypic and genotypic side of things. And our network really promotes these early stage companies from early idea generation all the way through commercialization now.
Dr. Goldman, what kind of procedure you follow, a process or protocol you follow to pick up a particular company, you know, that this is a good for investment? What are the requisites actually?
Great. That's a great question. You know, and again, our deal flow, now that our network has grown as much as it does, a lot of our deal flow comes from our members who get exposed through different conferences and through different relationships that they have that will come to us in the very early stages. So when we look at companies, at least up until recently, it's been mostly early stage companies. They're pre-MVP, they're pre-revenue, and they're developing out their products. And the way we do our due diligence is actually a very interesting way. So because we have the network, and the network has such a large exposure, what we do is we create a community around the potential company. We invite in their leadership. We evaluate their leadership from a perspective of being able to not only build a solution, but also to be able to deploy it effectively clinically. And then we bring in our advisors, our targeted advisors from our network. So let's say this is a solution that cuts across pulmonology and cardiology. We'll go to those communities and bring out the subject matter experts that we have that can help us look at it from a clinical perspective. We do the traditional, financial due diligence and technology due diligence through other communities that we have within our network. And then we decide at that point if we're going to invest in the company or if we're going to take the company and plug them into our network to help what I refer to as escalate them. So we're not just money being thrown at a company where what I've been told is referred to as venture capital as opposed to vulture capital, which is just throwing money into a company and trying to tell them how to run the company when you know nothing about the subject matter area.
You provide seed funding, right? That's a seed funding you do.
Fund one was all, our check sizes were about 250 to 1.5 million. So you can call that pre-seed, seed, and maybe even a little bit of a pre-series A kind of an investment. But yes, very early stage. But then we step in and we work with the companies to help them reach their milestones from a clinical and from a business development standpoint. And then now that we have a second fund, we're able to step in and do more later stage investments so we can follow the company all the way from early idea generation all the way through commercialization and exit.
Dr. Goldman, a lot of times doctors, I deal with a lot of doctors, that one of the things is that they are very emotionally attached to whatever they do. And the exit strategy is always challenging to them. When you say exit, they always, they become so emotionally attached to what are the procedures you tell them that you need the Silicon Valley model, you need to exit out, this is the time to exit out. That's itself is challenging. Tell us a little bit about that.
Well, it's interesting, again, because we get involved with the founders, okay? And of course, our wonderful friend, Uli Chetapalli and Innovator MD. And Uli and I have worked together for years now.
Hey, gentlemen.
That there's different components of it. But you're right. As clinicians, look, most of us are not educated. We don't have MBAs. We don't know really. We're not that experienced at running a business. And that becomes a very important concept to evaluate and understand who the leadership is of the company when you first start, because you're right. There are a lot of founders that if you get involved with them, they're not flexible enough and they're too involved in their idea to do the right things to get the company to where it needs to be successful, not only from an exit strategy, from a scaling perspective and reaching your milestones. And sometimes there are things that you have to do. And again, I've been there 3 times. Sometimes you have to know when to step back and let the big boys take over from a business development perspective. Got it? Okay.
Yeah, no, sorry.
So we spent a lot of time from a very early stage understanding who the leadership is and educating them about those exact things. But one of the reasons that I think we're more successful than most is they trust us more because we're their colleagues. We're all clinicians, okay? We're not just a venture capitalist who's either a finance person or a previous, technology, officer. We understand what they're trying to accomplish, but we're also there to reorient them a bit to reach what we're trying to accomplish. And the impact name doesn't hurt, right? That's right there. Because we aren't only interested in money, we're interested, and the wonderful thing about digital health is that it's deployable to the most remote places of the world most of the time, to help nations that have, and places that are very remote that would normally not have access to this kind of care. And that's a very important part of what we try to emulate as a network and a fund, but also what we look for in the founders early on.
I don't know whether you deal with the non-physicians or not, but I came across a lot of IT people who are starting healthcare companies. What they do, they have a cousin or they have some uncle or some brother is a doctor. That his knowledge is limited and a focus. So whatever the advice they get from the brother or cousin or brother-in-law is always limited, and it becomes a problem for other people. Really, that project will not a global thinking is not there. So how do you deal with those kind of people? That is a challenge.
Well, that's an interesting question because it's something that you learn over time. It doesn't come overnight. So one of the things, again, as a serial entrepreneur myself, what you learn as companies evolve, right, as they grow, as they scale. If you're dealing with a company that's developed in the United States versus developed in, a more remote place, in the U.S., once you get over the hurdles that we have, like the FDA and those things that you have to do to actually get to commercialization and market, it's much easier to deploy and scale your company. But a lot of those companies, if you're truly looking for an exit at a very good valuation that's also promoting the social change that you want, you have to be able to commercialize the product internationally. And that's a very hard thing to do. And for most companies, they tend, if they fail, that's where they do fail, because they don't have the right relationships. They don't have the cultural understanding of going into different places and going to the right organizations to get that commercialization in place. I've seen companies waste millions of dollars and not succeed. So what we're trying to do on the network, again, a network of their colleagues, is as we are doing our global expansion right now, as we go into a new region, again, like I mentioned, like Africa, like India, like the Middle East, the first thing that we do is learn about the location and the kind of technology that they need and what they're developing in country. It's pretty incredible, some of the technology that's being developed, very high-end technology, in places that are very remote and don't have that many resources. So if you get to work with those companies and then learn who are the appropriate business development partners, technology partners, the hospital systems that would deploy these solutions, if you can develop a relationship with them through the relationships that you're forging in those countries, then the companies that you invest in, then you can make those appropriate introductions and smooth the path for international commercialization. But it's a very complex environment. And in healthcare, in a way, it's easier on one foot and more difficult on the other, because we are a tight-knit community as clinicians. So when we bring this in, and we're from a credible source, which we are, we're listened to when we get there. But then you need to understand who's on the other side and what they're looking for, and understand there are some places where you're not going to make, a 10x return on bringing the technology to that area. What you're going to get is an ability to deploy the technology at volume and improve people's lives. So it's a balance. It just depends, and you have to really do your research before you you delve into that for a company.
You made an excellent point, actually. That is a cultural understanding, right? So, for example, in India and Africa and Afghanistan, I had a lot of bush hospital. That what I did was, at the time, there is a lack of they don't have a radiologist. And there was a small group. We have a Yahoo group. She used to be there in the Yahoo medical imaging group. I sent somebody from Pakistan, in the border of Pakistan. There is a city in Pakistan border to Afghanistan. I sent a radiologist from there, connected to the Afghanistan Laura Bush Hospital. So this is a cultural understanding, but particularly pregnant woman is a big thing. Is a pregnancy network is a huge problem. That's a big, we don't understand that kind of problems in this country, but is really these are the problems are like a pregnancy and then infectious diseases, very culturally different and geographically very different situations. They need to understand. They're absolutely right.
And
go ahead.
What's fascinating about that concept also is that, again, when you look at technology and you look at promoting different companies, there's a lot coming out now. Look, at the end of the day, I usually won't admit this publicly, but the pandemic is the best thing that ever happened for digital health.
Absolutely.
And because it really made us move to the next level of deploying technology to be able to care for patients. And because of that, now there are companies that are evolving whose sole purpose is to leverage technology for rural areas. So it's rural medicine. Then there are places that are forming the ability to provide care in a kit that has all of those remote devices on a cell phone that you could provide to a very, very remote, poor area for pregnant women, monitoring babies, doing things that we could never do at the point of care, which we can now. So really, the world is our oyster as long as we make it available in a way that enables us to get it to those places.
Works in those kind of places. But, let us talk about a little bit of skepticism. I'm going to talk about a little bit. The doctors are, EMR produced efficiency, but not productivity. There's a lot of criticism of EMR. It is not a feedback loop. You do this my way. It was a challenging for a lot of doctors. And I used to work in Atlanta. I used to go and install for the doctors all the medical devices. And I used to go to the doctor. One doctor used to tell me, his name is Dr. Shah. Hello, Dr. Shah. He used to be scared of going to the exam room. That he said that I scared of this, the number of buttons he got to touch. He got to do, I don't know which, I'm putting the wrong, pressing the wrong button. I am more worried about not the patient. I'm worried about that computer, what I'm touching. And this became a bigger problem for a lot of older doctors. And even this becomes a problem in general. The EMR did not produce the expected, the flowers that is expected, a lot of them.
Yeah, well, look, I could go on a whole soliloquy about that subject, especially after working as a physician lead informaticist for a 27-hospital system for a lot of years. We were implementing Epic at the very early days, okay, where we were going to very well-established hospitals like here in San Francisco, CPMC, and, all these great places. And there were plenty of, I won't use the word elderly anymore with this gray hair, but older clinicians that I would sit down and we'd be training them, and they would say, well, I'm not using this. I can't use it. I won't use it. And I can think back, and it's a little bit tongue-in-cheek funny, because I would sit there and, look, I had a job. I was there to train them. And the reality is that as of, let's say, February 31st, we're going live with Epic. And if you're not using Epic, you're retiring, you know? And I found myself actually, so this is a cute little story if we have a minute. When I first started, and it was with my first company, so they were putting on a conference at Stanford at the time for physician executives that were in technology, okay? And there was a handful, but it was a meeting that happened there. And this is in the days of Hillary Clinton and Newt Gingrich, okay? That's how long ago it was. And I remember that Newt Gingrich got up on the stage.
He's from my state. I know him I met him for a couple of times.
He gets up on the stage and he starts to give his, you know, his lead speech. And he's sitting there in front of all of these physicians who are executives. And he's talking about electronic healthcare records. And this is before electronic healthcare records were even mandatory, right? Yeah. But Hillary was his counterpart, and the two of them were, you know, and he gets up there, and they were all working together, and he said, look, he said, how many of you in this room remember the first ATM? And of course, everybody raised their hand, right? And there was a lot of gray hair in that room. I was a young guy in those days. And he said, so remember when the first ATM machine came out, how amazing it was that anytime, day or night, you could go to a bank, put a piece of plastic in a machine and get money out. You had access to your money 24 hours. He said, now think about that. That was 25 years ago. He said, how many of you now would ever even work with a bank that didn't have access to ATMs? And everybody, of course, shook their head.
That's a great point.
I'm going to make a prediction. He said, 20 years from now, everyone will be using electronic healthcare records.
Yeah.
He said, and if you're not, you will retire.
Yeah.
And I remember sitting there at that point and saying to myself, God, what a jerk. You know, that's never going to happen. And then fast forward 20 years later, I was sitting at one of our hospitals with an elderly physician who was going, I'm not going to do this. And I looked him straight in the face and I said, look, don't shoot the messengers, but I'm telling you that as of February 31st, if you're not using this, you're retiring. And I said, oh my God, I've turned into Newt Gingrich.
Yeah, absolutely. Let us talk about a little bit about artificial intelligence, Dr. Goldman.
Yes, please.
So a lot of the United States, not only United States, China, and the other countries are becoming older. People are getting older, and the baby boom generation, and they need artificial intelligence, AI agents to help them to organize their medications, organize their health data, all those things. Getting complex this data. So you think the AI agents could help and really take us to the next level and help these older, elderly people like me and you or anybody else, so help in the future that AI agents are going to play a role there that really help. That is where, instead of talking about artificial intelligence somewhere in the abstract, it is a real practical solution is that helps the older people. They need medications. They need somebody drone can go and get it, the medications even. That kind of things. What do you think of the artificial intelligence role in the future in the healthcare?
So it's an interesting question, but the first thing that I'll correct is you will never hear me use, when I say I don't even like the term AI, but when I do use it, I refer to it as assisted intelligence, not artificial. I always joke that, after doing all the things that I've done all the years, I'm very good at getting a bunch of clinicians in a conference or in an auditorium and talking to them about the future of healthcare. Okay. But if you ever want to clean the room out of everyone that's in that audience, use the word artificial intelligence, because what they hear is, oh yeah, you're going to replace me with a machine that's going to be able to be the doctor. Well, that's not the and there's a lot that's coming out now from an educational perspective that addresses this issue, and they've renamed it with different names. There's humanistic intelligence, assisted intelligence. There's all these other terms, which is to get the point across that the purpose of this technology is to assist the average clinician to be a better clinician.
I love that word.
To assist the patient in being a more compliant, better patient, okay? To help us as a system, I said earlier, I believe that the future of healthcare is the data, but there's a big caveat to that. It's what we do to the data, how we manage the data, how we use the data, and who owns the data, okay? And unless we address all those issues, there is great potential for it going awry. Like you said, look at electronic healthcare records. If they turned out to be the great thing that Newt Gingrich told us, no, they are very limited in many ways because they don't always represent the clinical workflow that needs to happen. And sometimes they make us, especially from a documentation perspective, more inefficient in the act of it. But the fact that we're collecting all of this phenotypic data and genotypic data will change the way we practice medicine over the next 10 to 15 years. Because, if you think about it, there's so much that we have to process as clinicians and educate our patients to understand it so that they can be good patients. But it's a huge amount of information. What do they say? That every 75 days, the amount of medical knowledge that is increasing, it's every 70 days it doubles at this point because of the technology that we have. So, I'll give you an example. I read an article, okay? Let's talk about, the areas right now that are really taking advantage of things like assisted intelligence and data management and technology. One of the clear ones is radiology, okay? Another one will be behavioral therapy now. Now it's so much easier for behavioral therapists to interact with their patients and not have to see them. It can be done remotely. It can be done on a phone. There's lots of ways to take advantage of the technology. But here's an example. So in the country, in Ireland, okay, single payer system, if you look at mammograms, okay, right, most mammograms are screening mammograms, right? So what's the first thing that you want to eliminate in that first mile of a mammogram? You want to rule out pathology, not trying to hone down on what the pathology is, but you want normal versus abnormal. Well, in that country, they have a shortage of radiologists, and they have a system to ensure quality that every mammogram has to be read by 2 radiologists, okay? But they don't have enough, especially, let's say you do 10,000 mammograms a quarter, okay? They don't have enough radiologists to do that. But what if we were able to take machine learning / assisted intelligence and have it read those mammograms in a way where all you're looking at that stage is saying it's either normal or it's abnormal. We're not going past that at that point. If you can eliminate, if out of those 10,000, 60% are normal, okay, because it's a screening process, right? If you can eliminate 60% of those exams in a very highly effective, sensitive, and specific way, which you can, then all of a sudden those reduced number of radiologists only now have to engage in the pathology mammogram, so they have enough people. So that's the first mile. But on the last mile component of it, this is where the real value is, if you think about it. Because on the last mile, let's say you've done your biopsy and you know the pathology, and now you have to diagnose it or come up with a treatment plan for this particular pathology and diagnosis. Then all of a sudden, you really need this assisted intelligence and machine learning, because what's going to happen is ultimately, with all the data that we're collecting between the genomic data, the phenomic data, the actual film, they're going to be able to look at a large, huge population of patients and say, with all the patients with this genotypic profile, your digital DNA, there's going to be some overlap of those individuals. And of all those people that came up with this pathologic diagnosis in this mammogram finding, this was the best, most successful therapy in that group. So real precision medicine. And our ability to be able to more effectively take care of patients in a faster, higher, more improved outcome way is going to happen based on us leveraging this kind of technology. But it has to be done right.
Yeah. Prime Minister Modi, he recently mentioned that, he said that he was talking in a Paris conference, in a AI conference. He was saying that I just put my problems in health problems, and it gave me the answers. The Chat GPT or whatever that is he was using gave him the answers in a very simple terms in his language, the Gujarati language that he is not a very good in English, but in a simple language, no technical jargon. This is that he explained to him very well, and he was impressed. As an older gentleman. So, do you expect in the first phase, assisted intelligence is for the doctors, or going to be the patients in general, patient compliance, patient all those things, or simultaneously happen in all these?
I think it's going to be a balance. It has to be both. Yeah. And it's interesting because we're always again per the idea of assisted versus artificial, right? Yeah. On the clinician side, I mean, all of us, you have friends and they have to go for this or that. They'll always say, "Who should I go to?" Is this a good doctor or a bad doctor or whatever? And my response has always been over the years, look. Understand, doctors are no different than anyone else. There are good plumbers and there are bad plumbers, okay? And there's always going to be some that are better than others. But with assisted technology, I believe that if you look at like anything else, you draw a bell curve over it, there's going to be on the left side those clinicians who, maybe they picked the wrong specialty or whatever, but they're not that great at what they do. Okay, but the majority, the super majority, are in the bell curve, and they're good. But what assisted technology will enable all of us to do is to make the left side of the curve better by leveraging the technology.
You made an excellent point. I tell you about that a little bit, if you don't mind. I'm from a small village in India. My father is a small-time doctor, small village doctor. He's an RMP, is a small doctor. One thing, he would have done wonders if he had the AI assistance to him. He can, read in his language, or at the time he speaks English. But a lot of rural doctors they don't have the knowledge of all the medical knowledge. They could have done better with the AI assisting them, telling them. Now I say that give them just basically a remote patient monitoring system, a wearable devices, and then get all the basic data. You can get a state of the picture of the health, and then the doctor AI can assist them to analyze that problem for them, and then can give up basically diagnosis and prognosis and all those things. It can do better in that sense. There is that area is a huge opportunity. Dr. Goldman, you made an excellent point. You're mentioning in the United States, but in its rural areas in India and in Africa would be a blessing in that sense. Do you agree?
Absolutely. And on the patient side, again, as physicians, right? Now we'll assume that we're talking to a group of physicians. Half the battle is also the patients, right? Because you could be the best doctor in the world, but if your patient is not compliant, okay, and doesn't follow what needs to be done, then the outcome is not going to be as good as it could have been. And what I'm seeing in a lot of the companies that we've invested in, a good example is there's a company called Plethy. It's a musculoskeletal monitor. It's the size of a quarter. You can put it on any joint. And it monitors for orthopedic surgery, for pre-op, post-op, for musculoskeletal disease, workers' compensation. It monitors compliance. Are you doing what you're supposed to be doing? It monitors progress, range of motion, force of motion. But more importantly, it lets the patient know when they're not progressing the way they should be. It lets the surgeon know and the physical therapist know, and they're all working together. Without that, there's a lot of patients that just don't do well because they're not doing what they're prescribed to do. It's not just medication, it's physical therapy, it's all those pre-op, post-op things that need to happen. And those kind of technology will significantly improve our outcomes because it assists the patients in doing the right thing. And when they're not doing the right thing, we don't even have to ask, because now the system tells the provider that your patient is not being compliant, and you have to figure out a way to improve that.
Dr. Goldman, I wanted to ask you the last question, one of the last questions, then after that I can mention about. Let me ask you about cancer. Cancer is one of the hard one to crack. and people are getting older, a lot of cancer. What do you think this AI or this assisted intelligence or artificial intelligence or this quantum compute? Do you think we are going to crack this problem of cancer? Eventually, we find a solutions, treatment. And, the claims are bigger than real. What you see. That one of my good friend, a lawyer friend of mine, is a Roger Royce. He mentioned everywhere on the internet, so I don't have to. But he's a great friend. But I see that this kind of people are going through this kind of things. It really, I feel that we are lagging behind somewhere. I think technology is going to do something different here, and we're going to find eventually the Holy Grail.
Well, I think, again, it's all going to come down to data and what we do with the data. Data is going to enable us to crack those codes, okay? But we have to be able to be handling the data properly and analyzing it properly and then deploying it properly, right? So it's everything. It's not just one part of it. It's the entire care continuum, right? So there's the preventative part. So if we want to talk about the preventative side of it, okay, well, genomics is going to be incredibly valuable over time because we're going to have global populations of data that are going to be able to show predispositions based on genomic profiles for certain diseases, and then using the assisted technology, help those patients to live a life that moves them in the right direction, very precision-based. But that's just the preventative part. But then once you get the disease state, but now, and I talked about it, alluded to it a little bit earlier, is that, making the diagnosis, like we talked about the mammograms, there's the diagnostic part of it. So how can we leverage technology to be able to do more screening on more people and process that information in a way to help patients from a screening perspective. But then once the diagnosis is made, to me, this is where we're going to make strides. And it's like what I talked about before. You're going to get a diagnosis of a particular malignancy, and it's going to be able to go into a database, a global database of patients that have a similar genotypic profile, that have been treated retrospectively in the past. We've been collecting data for 20 years now. And prospectively in the future to be able to say, okay, with this genomic profile, at this stage, with this onset, this is the right treatment. So we're not going to do sick care, shooting at a dartboard. We'll try this, it doesn't work. We'll try that, doesn't work. We'll try something else. So I think our ability to hone in on the right treatment will definitely be important. And then, again, moving into the future, what we're going to be able to do from a genomic perspective in terms of manipulation of genome, manipulation of cancers from a genomic perspective. I think the world is our oyster with respect to that. What's who Ray Kurzweil is? Hey,
He's a futurist.
Yeah, I've read all his books, but my favorite book of his was How to Live Long Enough to Live Forever. Because when I was reading the book, I was unfortunately reminded that I'm too old to take advantage of a lot that's what's going to come down the pipe over the next 20 years. But our kids and this generation, when they get to our age, our ability to care, to prevent, to treat is going to be off the chart, and then longevity is going to be significantly longer. And I'm not sure if that's a good thing or a bad thing, the way the world is going. But yeah, I believe that it's going to radically change how we take care of ourselves and how we take care of patients.
Complex problem I was mentioning, you need a wisdom. Wisdom only comes with the age. There is no way young people can solve a 19-year-old kid to understand the healthcare problems. I wanted to ask you the data. Another question is the data itself. You are mentioning about the data. Who owns the data? It's a more of a not a technical question. It's a legal question. It's a policy level question. So I think that we need to work on this policy level. All the data should be much more available than it is a proprietary kind of thing. Epic is going to keep its own data. Pharmaceutical companies want to keep their own data. So this is one thing we need at the policy level has to be changed. You have any take on that, Dr.?
Yeah, well, we could spend a whole nother hour on this topic. Because there's one area which I've been spending a lot of time and a lot of sleepless nights thinking about. And that's, our current system is a sick care system with very misaligned incentive systems. And I believe, and again, I am certainly not the great Kreskin here, but I believe that within 10 years, the whole system is going to change, and it's going to be based on that data from a compensation perspective, from a care perspective, from a revenue generation perspective. If you look at the current system right now, okay, it's driven by who? It's driven by the insurance companies, in our country at least, okay? And the patient is also, in many cases, an employee that has to be provided insurance by an employer who has to spend the money for that insurance. But if you look at it, who's the best patient? Best patient is the youngest, healthiest patient, okay? That's because they don't cost anything to the system. Yeah. But the reality is that their database is, maybe from a preventative standpoint and a genomic standpoint, some value. They're probably the least valuable patient in the system.
Absolutely.
But who's the most valuable patient from a data perspective? The most complex, elderly, multi-system disease patient is a database fortune for what we're trying to accomplish on all sides of that workflow, right? So what if we had a system, again, and it could be a global system, where you as a patient are working with, forget about insurance and employers and all that, there's a system that's a data broker, okay? So now they work with you, okay? Your DNA twin, okay? Your DNA twin is essentially, you're the author and that's your book, okay? And if there's someone representing the patients in a way where our goal is to provide the best care at the most efficient way, and not the least expensive, but certainly the most efficient expense way to take care of that patient, which includes everything from, again, prevention all the way through treatment, okay? What if there was a system where the data broker system says to you as a patient, okay, your data can be used either in an anonymized way or a de-anonymized way, okay, which is you. And the reason we worry about anonymized data right now is because, God, is the insurance company going to charge me more insurance if they find out about X, Y, Z? Or am I going to be, treated differently because I have a diagnosis? But what if the system said, okay, well, look, we're going to guarantee that you're going to get the best care possible based on the data that you're putting into our this database, which is accessible, okay? The monetization of the data, which it's happening all over the place, but not to the benefit of the patients or the employers or anyone. It's to different, depending on where you are geographically, it's not clear exactly how that works. But what if there was a central database that gave access, the patients gave appropriate access to it, but in exchange for that, the part of the data management that allows it to be used by the pharmaceutical companies, by the clinical studies, by those areas that pay for that data. And those dollars could then be appropriated for the care of the patients and also appropriated for the improvement of health care. Then all of a sudden, when you look at those kind of systems and you talk at the data, and you look at the data analytics and you look at the actuarial data, the reality is that data will generate enough revenue to pay for your care, okay, to reduce the amount of cost for your care by your employer, and it'll also do all those other things that we said. If we have a global database, how it'll improve care. So in essence, it's a comprehensive care system that's not an insurance provider, but it's working to improve every aspect of the care, including the patients and including the providers and including the improvement in healthcare. And that's very viable.
Yeah. I can talk with you hours, Dr. Goldman. You are very interesting to listen to. Let's talk about your fund, a little bit. And how do the doctors want to invest with your fund? What are the procedure? What is the protocol? Just to give us a little bit of brief.
So again, we're Global Health Impact Fund and Network, and our website is, globalhealthimpactfund.com. But, we focus in on health. We're a network and a fund which is founded and managed and driven by health professionals, right? So the funds utilize the investors and the network members to pick the right companies that achieve everything that we've talked about today, but also look at them from a fiscal perspective. But if you do the right things, then the time to exit and the valuation of the company and the multiples for exit will definitely be improved because the network helps with that. So any healthcare provider that's interested, you don't have to be an investor. And, only 99 investors could be in a venture fund. So, of course, if you want to, you got to jump in and do it. But more importantly, you can also get involved as just a member of our network and learning and educating yourself about innovation, about healthcare and technology, and how to become a resource for these companies that are doing it. And if you've got good ideas, our network can also, along with, Innovator MD and ULI and SOAP, Society for Physician Entrepreneurs, there's so many resources out there to help clinicians take their ideas and develop them in a way that improves healthcare innovation. So it's, anyone can reach out to us. Anyone can join our network. We don't charge for membership. So what I would say is just reach out to us. Anyone could reach me at Gary@globalhealthimpactfund.com. And we would love to get them involved at a very targeted, specialty-specific way, or at a global way of helping us improve healthcare.
It is truly an honor and a privilege to talk with you. You are a source of information is unbelievable. You can you can talk, and you're a really impressive talker. Thank you so much. I think it's a wealth of information you gave, and I think we are moving is a positive optimism is a very good. I love your word, assisted living, assisted intelligence is the best way to use in healthcare. I love that word because that is the best way to convince people what is AI is, what is the meaning to that AI. So to the relevance to the patients, the relevance to the doctors, it makes a lot more sense. Thank you so much. You are the inventor of the assisted intelligence. Thank you so much. I'm truly an honor and privilege to have you. I hope you like our podcast and you promote our podcast. You watch my podcast once in a while, and please watch regular. Thank you, sir.
Yes, and I want to thank you for putting on this wonderful podcast. We've known each other for quite a while now through this. And, absolutely. And we've talked about it. We want to we want to promote your podcast on our network globally. So let's get that going.
Yes, sir. Thank you, sir. Thank you for so much. If you can wait for a couple of minutes, I'll close this one and then talk with you on the after show.
Of course.
Good night, all of you. Good night.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.